The last talk of the afternoon, so we'll get a chance to start the reception a little early. See if we can make sure we get those. Presentation, Terry Baskin's going to talk about RxResults.
My co-presenter is on his way.
And his co-presenter, Chris Monroe.
So we're the only thing standing between you and the cocktail hours.
That's correct. That's correct.
How do we move forward here?
Probably this right here.
Terry,
Yes.
to
this microphone?
The streaming.
Well, before Chris starts, I wanted to say one thing about Dr. Unger's presentation. Those of you that know me well always know I have some comment about everything. When he was talking about hemorrhagic pig shock, I thought that's what happened to the Razorbacks in Birmingham a couple weeks ago, or Tuscaloosa, so I thought that's what it was.
We appreciate y'all's time. My name is Chris Monroe. This is Terry Baskin. Our company's called RxResults. And I'm going to give you a brief overview of what we do from a real high level, a little bit of background on where we came from, and Terry, who's a pharmacist and our founder, is going to dig into the clinical components and more of an industry outlook of where we fit into the employee benefits market. We are what we call an evidence-based formulary management company. Now, I recognize that's a mouthful, so I'll bring that down a couple thousand feet. We work with large self-funded employers in assisting with reducing prescription drug costs within an existing pharmacy benefit plan. And we do so we're doing so by commercializing an independent, unbiased research model that was created and housed within the College of Pharmacy at UAMS. We are a true joint venture with UAMS. UAMS is a small owner of our company. And we're commercializing this independent research model in an effort to reduce prescription drug costs for large employers. It's important to understand where we came from to give you a flavor for where we're heading. And I'm going to go back to 2004 when Dr. Joe Thompson, the Surgeon General of the state of Arkansas, approached the College of Pharmacy on behalf of State Medicaid and State of Arkansas Employee Benefits Division, roughly 700,000 Arkansan lives, with more of a challenge out of frustration from the existing pharmacy benefit management industry. Lack of innovation had created escalating costs, and so from that challenge, he said, is there anything that y'all can do from a research standpoint to help us reduce our prescription drug costs? So by that challenge, UAMS created what's now known as EBRX, the Evidence-Based Prescription Drug Program. When that model went into place for those 700,000 lives at Medicaid and Employee Benefits Division, the state saved over $100 million on their drug spend between 2004 and 2008. Based on what the chancellor thought of was a shining success, his challenge then was to create a private sector for-profit company to take this research model to other states, and other employers, and other payers. That manifested itself into RxResults. So we are truly commercializing the research model that came from the College of Pharmacy. Our management team is Terry Baskin. Terry is a pharmacist by education and also by practice. Has a career in the pharmacy managed care industry, started a PBM, pharmacy benefit management company here in Little Rock in 1989, sold it to a publicly traded PBM in 2000, spent the next 7 years as chief operating officer and chief marketing officer, which by acquisition was probably the 6th or 7th largest publicly traded PBM in the country. Alan Gardner is our director of operations. He's a graduate of UNC Chapel Hill, also has spent his career in health information informatics, also worked for Terry for 8 years in an operations capacity as well. I head up our sales effort, and I've spent my career in sales and sales leadership in various industries, most of which has a common denominator of solution-based startups. A little bit, for the sake of efficiency, we're going to roll through this pretty quickly, but that's an overview of who we are, what we do, and Terry's going to give you a feel for where we fit into the industry.
Okay, thanks, Chris. Just to kind of frame up the healthcare market and specifically as it relates to pharmacy. Today, the pharmacy expenditure, if you look at the total expense for a typical employee health plan, is approximately 20% of that. You know, compare that with 15 years ago, it was about 5%. So when you do the math on that, the pharmacy program is growing faster than any other part of that. There's an interesting subset in the pharmacy expense that's gotten a lot of people's attention, which is the whole specialty pharmacy area, the biotech drugs. 9-10 years ago, if you looked at total pharmacy expense, probably less than 1% of that would have been injectable drugs. If you look at it today, it's probably somewhere in the 17 to 20% of the pharmacy spend is with the biotech drugs. And the general sense is that that percentage is going to go to 30-35% in the next 3 or 4 years. So that gets a lot of people's attention. We're going to circle back in a minute to something that we hope to be able to do to address that. The problem that exists today is a good news, bad news thing. From our standpoint, it has created a niche market for someone that can come in with a new model that's swimming upstream or countercurrent, whatever you want to call it, to the prevailing models that are out there. The pharmacy benefit managers that exist today have frequently a potential conflict of interest, if you will, on how they make their revenue. A lot of that comes from the pharmaceutical industry. It's difficult to manage cost for, if you will, to use the more efficient choices that are available if a lot of your revenue is coming from those people. Now, that's not to say that everyone does that, but that's certainly the prevailing model. If that practice didn't exist, there wouldn't be any reason for us to be out talking to customers about an alternative model. So the PBMs that have been tasked with controlling those costs, for the most part, most people aren't satisfied with the outcomes or the results that are being produced. The pharmacy benefit consultants, they have, in some cases, those folks actually get paid by the PBMs, and that's fairly simple to see why there could be a related conflict of interest there. And then a lot of those, and I would say for the most part, and the folks that we're working with as channel partners and those types of things, they get heavily involved in procurement. They get involved in audits on the other end of the spectrum. But we have run into very, very few of those folks that have any kind of a clinical initiative within their model. So there again, that creates a need for us to be there. When you look at what we do, and we've done this now, I guess the first time that we were here was in October of 2008, so 3 years ago. We were back again May of 2010. We had actually not even started in 2008, so we were all, talking about what we were going to do. We now have, and Chris will touch on a little bit of the detail of this, but for the clients that we have, we are reducing their total pharmacy spend in the range of 10 to 20%. Now, if you remember, what I said early on was that 20% of the healthcare dollars being spent on pharmacy. So if we save somebody 20% of that, that's an overall 4% reduction in their total healthcare cost. And that's getting a lot of people's attention. This has been done with a process that's being driven by the College of Pharmacy. When they review those choices, and we build all of our strategies and tools to move patients to those drugs that we've targeted, having the College of Pharmacy involved in this has created a very sense of confidence, or there is a confidence that the college is not going to do anything to harm a patient. And there's not always that same confidence with some other models that exist out there. The unbiased nature of the college and the university is a big benefit for the clients. We've reaped a lot of benefit of that as out in the marketplace. And also the fact that they've done this since 2004. We're way past the proof of concept, so that's a good thing. We're out explaining this in the marketplace, and we get very, very few questions about the clinical basis of our recommendations or the financial impact and the fact that we've got so much business that kind of backs that up now. Market size wise, just to give you a quick frame up of that, there's about 235 million folks in the United States that are covered by the pharmacy benefit management market. 91% of all the prescriptions in this country are processed through a PBM. So if those folks are not producing the same kind of results that we are, you can see that there's a pretty good opportunity. I guess we had our initial projections, and we'll talk some about that. It takes about 100,000 lives for RxResults to break even. With some of the things that we've learned in the last few months, we've moved that bar up just a little bit because we're going to increase some of our services. But one interesting fact that's not on here, we get a data set from a client. We apply the College of Pharmacy's rules to that data, and then we will project a savings, do a savings projection for that client, for their employee benefit. We've done roughly 120 of these projections to date. All 120 of them, we were able to save the client money. The lowest one, we probably got a handful that were in single digits, probably have the same number that were over 20%. The other 110, if you will, were between 10 and 17% projected savings of the total drug spend. So we're now at the point where I believe it's statistically valid to say that this model will produce savings And right now, we're 120 and 0. So there may be someone out there that's not doing this. Now, that's a good news, bad news. The fact that it creates that opportunity, we're also still in that early adopter phase. You know, I walk in and tell you I can save you 15% of your drug spend, then it's valid. We do get questions, and you can almost read it on their face. If this is such a good deal, why isn't everybody doing it? And so that's a legitimate question. Those of you that have started new companies and new processes understand that that's something you face every day. So we're kind of on the tail end of that now because we've got so much business, but that is something we've experienced. Chris is going to jump in here and tell you who we're trying to sell this to.
And to expand on what Terry was saying, what makes it interesting is the pharmacy benefit manager tasked with making drug recommendations don't always make lowest net cost recommendations, and that's primarily because of their relationship with the pharmaceutical manufacturer. So that does create a delta for us to show up with an independent, unbiased set of rules to strip away a little bit of fat from that component when there is a lowest net cost that's readily available that does not affect the clinical outcome for the patient or the member. So that's what creates that opportunity. The markets we're pursuing, very similar to the group we heard at lunch today, we're pursuing the self-funded employer marketplace. We're pursuing employers on a direct basis, what we call in a retail capacity. We're also working with various channel partners, what we classify as in a wholesale capacity. We're really looking for employers with 1,000 employees or more. We now currently have clients in 4 different states. What's interesting is that our wholesale prospects, our potential channel partners, could also be classified as potential competition as well. We do have the largest privately held PBM in the country actually is starting to weave our clinical components into their service offering to their prospects and their clients. So it's an interesting dynamic that the markets play in both ways, that what could be competitors within our space are also target clients of ours. This is a little busy, but this does give you an example of some of the clients that we have to date. We now have 18 employer clients to date in 4 different states. We've gotten a lot of traction in the public sector market. One of the reasons we feel like that's the case is most public sectors will act as a fiduciary on behalf of their employees and their members. Secondly, typically they're not able in a financial capacity to afford some of the larger national or regional consultants to assist. So by utilizing our product, they also get a pharmacy consultant along with it. So you see quite a bit of traction in the public sector arena in 4 states, Texas, Michigan, North Carolina, and Arkansas. Some familiar names on there, I'm sure. And then these are some of the prospects that we're working with. This is listed as new clients and prospects. We have a budding relationship with HealthScope Benefits, a TPA here in town. And then you'll see some of the others, most of which are in a public sector capacity. We're actively talking to the state of Utah and their health benefit plan, state of Michigan, state of Wisconsin, any one of which would be game changers for us. City of Houston, City of Austin, Texas Medicaid, and we're also talking, just recently initiated conversations with state of Illinois Medicaid. So just to give you a flavor of some of the employers that we're visiting with in the marketplace.
These next 3 slides are going to show you a couple of things. You know, I mentioned a few minutes ago about the 120 savings projections that we had done. This particular one, and you don't necessarily need to worry about the particular therapeutic categories, but when we do the savings projection, we'll break those down by category, and then at the bottom of that you see the $2.4 million. That's what so if I could get Alan Angstrom to do the math real quick, 18,000 people times $20 per member per month works out to be a lot of money for a year. In this case, we're projecting it to be about $4.4 million a year. That $4.4 million was based on the slide that I did previously, and they asked us to help them renegotiate their PBM contract in the midst of that. So there was a combined effect of those 2 things, but this is the kind of thing that we like to be able to go out and tell the story about. You know, the name of the company, RxResults, was picked in anticipation of these kinds of results, and this is what we're trying to sell. These are the metrics on that particular group, and this is all what was on that graph. The next to bottom line there is something that I want to point out to you because this is a big key component. Frequently, when you talk about saving money in a health plan, the members' employer average copay went first quarter from $1,541 down to $1,283. It bumped up a little bit the next month because we added some specialty drugs in here. But the average copay on every client that we've got, the average member copay has gone down. So this is not something that, this does not cost the employees money. This also saves the employee money, and we're beginning to spend a good bit of time on that. This slide is a couple of things I want to show you out of this. We make money two ways from the client, either a per employee per month basis or a per claim basis. And the important part of that is that the only source of revenue that we have is from the client. There is no money from the PBM, there is no money from the pharmaceutical company, and that's not to say that Chris and I rode in here on a white horse, but the integrity of this model to be able to, if you will, answer to only one master, that really is necessary for this model. From a return on investment standpoint, I'd like to share with you, I think Chris mentioned that our range has been from about 5 to 1 up to about 17 to 1. The client will save money. In this case, they were saving, let's see, it wasn't this client, it was another one in Texas. They were paying us about $13,000 a month. So the first month that we billed them, they saved $150,000. We sent them a bill the 1st of February. They paid it about the middle of the month. So by the time that they wrote a check for $13,000, they had saved $180,000. So they were never upside down. With all of our clients, they're always going to be in the black, and that's also a good selling point. Now this kind of gives you a little bit of a sense of where we've been over the last 3 years. You can see that we got a little bit of consulting revenue in 2009. First client started in 2010. We expect to be a little over $700,000 this year. Now I want to point out that our projections are based on what we're doing today. It's a very conservative projection based on, just organic growth of us doing what we're doing, continuing to do that. And it's a good story, but we do think this is rather conservative. We're going to get into a couple of things that we hope will change those projections. Those are the projections we're operating from today. But what we've done, and you can see from our timeline here, is we started to get our first business. We went through a lot of the conversations, the early startup kind of things, getting all your ducks in a row. Started to get the clients. As Chris mentioned, we have 18 clients now in 4 different states. Now about 4 or 5 months ago, we believed that it was appropriate that we stop and look at what's going on relative to people's adoption of our offer, if you will. So we've talked to a lot of prospects, talked to some clients that did business with us, and we wanted to know if you're not adopting it, why not? And I think our team's experience has been that we believe what the college did has a huge amount of value. We've actually validated that. The graphs that we showed you earlier, the savings is there, and so that was our initial thrust, and we thought that in and of itself would be compelling enough to make, not everybody, but a lot of people say yes. If you ask my wife, she would probably say, why didn't everybody buy it? So what we found out was there were 3 principal reasons that we were hearing from people, or 2 reasons, I guess, that they weren't doing it, but one other thing they wanted. The first thing was the perception of disruption. So you're going to change my employee from drug A to drug B. What's their doctor going to think about that? What are they going to think about that? So that's an important consideration. So we're going to do some things that I'll address in a minute to address that piece of it. The second part was it seemed a little bit aggressive to them. They believed it. The numbers are there. We've got plenty of evidence to prove that. But they weren't sure they wanted to do the whole thing at once. So our answer to that is that we're going to do a couple of different things. One, we're going to put in a highly expanded communication education process so that we contact people on the front end, not just with the letter we send today. We're going to put in a both inbound and outbound call center function. We'll look at the data. We'll identify every patient that's going to be impacted. We'll call them before the go-live date. We'll tell them to explain the program to them, tell them they're going to be getting a letter in the mail about a week later. It'll have their specific situation. It's not the plan information. It's you're taking this drug, here are your choices. Your copays can either go down, they could go up. If you have any questions, call our call center at this number. We believe that we'll be in a better position to, have those conversations with our, the covered members ourselves. So that's a big piece of it. We have kind of field tested that. It's been amazing how those same folks that were concerned about the member disruption, how they've gravitated to thinking that's an excellent strategy. We're going to expand that just a little bit more. So after the first month, and depending on the day supply, we'll probably do it on the first 3 months. We'll look at the data and see those patients that have actually spent more money than what they had to. We're going to recontact them. So if we call you in February and say, Mike, you used a prescription in January that cost you more money than it should have, if you'll get your physician to change that prescription the next time you have it filled, not only will you save this amount of money, but your plan has agreed to refund you the difference of what you spent in January. So you'll get a mulligan, if you will, in the month of February. So the plans have heard that. They like that. We believe that increased education will go a long way. Because what we found out along the way of looking at this was that the disruption is the result of confusion. And so we think if we can do increased communication and education, that we'll get rid of some of that. I saw Mike move his microphone over there. I don't know if that was a signal or not, but we're just about through here. Let me talk to you about, from a financial standpoint, of where we are. We were funded originally. I put in the initial investment, Fund for Arkansas Future, and 2 angel investors put in around the second round of that. Now, what we have determined is that to do these things that I just described with the communication, there's an increased technology need to accomplish some of those, and using the data and how we do the communication, and then the staff to go along with doing those things. One of the issues that we have in our thought process of where we are in the stage of our company, we have a good product. We run into almost no one else in the marketplace that does what we do the way we do it. We also understand that if we begin to produce these kinds of results, that others are going to follow this. It's a model that, you can hear the use of evidence-based medicine in just about every healthcare reform discussion that's out there. People are going to start doing this. We think that if you will, the ramp-up time that we've got, the projections that we had on that slide of revenue, we believe that we can continue to grow that way and we'll have a good, solid company. One of the risks that we run is that if we take too long to grow, someone else that's very, very well funded could come in, do something very similar to what we're doing, and capture the market. We would have blazed the trail, if you will. Somebody else could take advantage of that. So what we want to do now is to identify a strategic investor. Y'all know as well as I do what that could mean. It could be you have another portfolio company that's of the size that could benefit of what we're doing. They could be a channel partner for us. They could be a complementary product where they're talking to the same people and probably using the same kind of data that we're using. We actually have a call set up Monday morning with one of the folks that did one of the elevator pitches at lunch. He approached us and said, we have got to do something together. He said, this is an absolute natural fit. And he said that we're talking to the same person, same data. He said, I would like to take what you're doing and weave it into what we're doing. He wants to present us to a client of his next Tuesday. So we're going to talk on Monday about that. So that's the kind of the strategic nature of what we're looking at. So that's where we are. We've started it. We're making a little bit of money, generating some revenue. We felt an obligation to stop and look at what we're doing, what we could do to improve it. We've done that. We do believe that we need to ramp this up faster than what our conservative projections have been. So we'd be happy to continue that discussion with y'all here or during the cocktail hour, or we'll stay as long as you want. Because again, those of you that know me know that I'll talk about this until you go to sleep. So anyway, thank you for your time.
Thank you.
Terry, I have a question first.
Sure.
So I'm trying to understand how your client would actually use this service. So you work out a plan, you figure out what needs to be done, and you contact, and so there's a set of savings. Does that have to be recalculated and reconfigured every year? Or is this something that once you've made sort of the decisions that are necessary, you set up the plan for them, they continue on, and then you have to find new clients? Is this a reoccurring sort of requirement, and therefore your existing clients have to continually be serviced, or is this a one-time? I guess it's a one-time versus a repetitive.
Right. That's actually an excellent question. Stuart McClendon asked us if we had recurring revenue or was this a one-trick pony? And I think that's kind of what you were saying. When we look at the at the claims data. We will certainly have an initial set of recommendations. We'll put those in place. As long as the pharmaceutical industry continues to act like they have for the last 50 years in developing or releasing Me Too drugs to the market, those drugs that have no additional clinical benefit to an existing choice, and you see that as a way to do one of two things, either to get a part of that market share or to do a patent extension, get a new patent for a new delivery system or something that really doesn't help anything, but it gives them a patent. It goes on. We looked at a 13-month period of time recently, and there were 65 drugs that came on the market in that 13 months that the College of Pharmacy determined were Me Too drugs. So as long as that happens, we'll still have a reason to be around. We have our client that started in 2010. We gave them our original projections. It worked out to be about $1.2 million that year. The second year, our projections were about $600,000, and these were new. They were still getting the benefit of the first year. And in August, I went to their board meeting, and we proposed another $400,000 worth of savings for year 3. So as long as the marketplace continues to do what it's done, we'll do that.
And I'll add this, from a revenue standpoint, it is recurring revenue. We have one client with a 5-year contract. The remainder of them have a 3-year contract, and we're paid primarily on a per claim fee. And so it's a click charge for every net paid pharmacy claim that goes through their benefit plan. So it is a recurring model for all claims that funnel through their pharmacy benefit plan.
But in addition, does that mean that you have to do new things?
No.
Or is it that once you've set up the plan for them, you have these click charges that are recurring, but in fact, your new staff can actually go on to new projects? Or in fact, do you always have to have somebody involved in your existing clientele because the decisions will change, the use of the evidence will change, and therefore change their cost margins?
Right. Well, you're correct. There is an ongoing need for us to continue to demonstrate value. We could do the one-time thing, have a 3-year contract, and then go away. But the fact that there are changes all the time, like I'd mentioned on the Me Too drugs, the biggest area that we're looking at right now is in the area of specialty pharmacy. We've just put together a specialty pharmacy strategy. We've got it in place with a couple of clients that started July 1st. Specialty is a huge area. There is the whole area of medication therapy management. That product is in the early stages of our development. So we're developing new products in addition to just the formulary management piece. The formulary management piece probably has a long life cycle just because of the Me Too drugs. So.
And also from a functionality, once we build, we don't take the place of the PBM. We're an ancillary clinical overlay of the pharmacy benefit manager. So we don't totally change their vendor makeup. We'll actually build our clinical recommendations within the adjudication system or the claims processing system of the pharmacy benefit plan. That's what gives our recommendations and our model immediate traction and ongoing traction. So once we've built it in during implementation from go live date forward, it's really a matter of, as the research evolves, that's our involvement. But from a functionality, the rules are built and those are in place until we change them based on an evolution within a particular recommendation. I think that's part of your question.
Yeah, I was just curious about your revenue model, and the thing that came to my mind as I was looking at this was, gee, why isn't it just a simple proposition? If you walked into me and you said, we'll save you $2 million and we'll just split it down the middle. So, but you don't, and I'm sure there's a good reason for it, but as on the per couple bucks a month or whatever per employee, is it competitive pressure that keeps you from doing that?
No, it's really, and I've sold several share the savings type models in the past. They get frequently kind of contentious second and third year. If I've switched somebody from drug A to drug B the first year, like Marie was saying, okay, at some point you're going to say, now how long are you going to take credit for that? I mean, that's what comes up. So, we like to show what the ROI is. Here's what you saved, and here's what we charged you, and that's pretty simple. But when you try to get into a debate with the CFO about, okay, now how do I know you did this and the doctor didn't suggest it? Or how do I know, there's just all those possibilities. So we've decided to stay away from that. One thing that we do to assume a little bit of risk, we will guarantee that a client will save twice what they pay us. And if we don't, we'll write them a check for the difference. So the worst they can do is double their money. So we got a little bit of skin in the game there. Anybody else? Yes, sir.
Two questions, actually. First, how much of the savings is moving to generic drugs and increasing the use of generic incentives as part of their whole pharmacy then? And secondly, be curious what else you have to do to have the PBM cooperate with you to get the data for you to be effective in increasing the results. And is the PBM an impediment to that process? I've seen that in companies like yours.
Right. I'll take the second one first. Certainly the PBM is the holder of the data. The client also needs to they understand that it's their data, and if they want the PBM to send it to us, we haven't had, I guess, like I said, we've done 120 savings analysis, so in all of those cases we certainly got the data. I won't say that it's always just a ask it and we'll send it over this afternoon type thing. Sometimes you have to go through a few hoops, but they understand that. The PBM relationship is maybe even more important as far as building all of our rules into their adjudication system. We will drive that implementation process. We'll lead that whole effort, but it's within their system, so it has to be done. And this is a real simple, if you will. I'm a simple person, so I try to keep it simple. We tell our clients that you really need to invoke the Bill Cosby policy, and then they look at you like, what are you talking about? So you need to tell the PBM that this is your plan. It's like Bill Cosby's dad told him one time, son, I brought you into the world. I can take you out and make another one just like you. So when the PBM understands that the client is going to do this, they're not going to fall on their sword. They're not going to lose the client because they don't want us involved in it. And so we've done this with 7 different PBMs to date, and it works pretty well.
I'll say this: our relationship. You asked a great question, because our coexisting relationship with a mutual payer alongside the PBM is dynamic, to say the least. We don't necessarily work with them. We're just along parallel paths working for the same client or the same payer. We really classify them into 3 different buckets. There are some large, publicly traded Fortune 100 PBMs who really don't want us a part of their space. But again, as Terry made reference to, it's really the client holding leverage of their own plan. Secondly, there's a cluster of PBMs who really don't care that we're within their space. Third of all, from a marketing standpoint, there is a group of PBMs who view us as an enhanced clinical offering for them to go compete with what we classify as the big 3. 3 publicly traded PBMs who take up about 65 to 70% of the market. I mean, the one that we have an ongoing relationship with and a growing relationship with views us as a silver bullet within their service offering. They are truly a transparent PBM, making their revenue on an admin fee versus rebates and misaligned incentives and up. So those are the type of PBMs who gravitate to what we're doing, have no problem including us within their service offering to their target client. So, we've seen all different spectrums, but our relationship with the PBM industry is a dynamic function of our business, and hopefully you kind of recognize both ends of that. So, good question.
You also asked about the generics. Certainly the vast majority of the savings is moving from a brand name drug to a therapeutically equivalent generic drug. There are some of our strategies that are adherence to there's an asthma drug that's a combination product. The National Asthma Guidelines say to use the inhaled steroid first before you use the combination product. There is no generic in that case. That's really an adherence to a national guideline, but the vast majority of the savings is moving from a brand to a therapeutically equivalent generic. Mike's
I
going to
think
ask a question.
the hour is late. Well, the only thing I wanted, the specialty, you talked about this, I think alluded to it, and that is the new biological, more complex therapeutics that are coming along. Is that relationship with the College of Pharmacy unique to you guys, or are there competitors out there that sort of try and generate those alignments?
There are a few people out there that are trying to do something to get their arms around the specialty spend and the care associated with those drugs. They're exceedingly expensive. The average retail drug, if you will, costs about $80 or $90. The average specialty drug, our client in North Carolina, was $2,800. So you can see the big cost difference. But the college is developing a series of protocols for each one of these drugs in the therapeutic category that they're in, and we've got some other things wrapped around that. I know of a couple, but I will say that anytime we mention specialty drugs in a client meeting, you can forget everything else that you came to talk about, because that's all they want to talk about is specialty drugs. That's also one of those things you think that I'm kind of dense, because if the marketplace tells you for 2 years that we want specialty strategy, we were in Dallas last week and Chris said, all right, by golly, we're going to have a specialty strategy. So anyway, we're in the process of building that.
And also, you make reference to others doing what we do.
Yeah.
We've had a unique example. We've had 3 public entities that are now clients say, look, we love what you're doing. By statute, this is going to have to go to competitive RFP. That's absolutely, we're comfortable with that. 30 days later, all 3 of them came back and sole sourced our product and our service offering based on their inability to find anyone else that occupies our space. So from our marketing standpoint, from a strategic standpoint, we are well positioned within a marketplace that we think is evolving that direction. And whether that's specialty or core formulary management, there's really no one else that occupies our space solely like we do.
Okay. Thank you very much,
All right.
gentlemen.
Thank you.
Great story.